To keep things organized, our agenda follows a neat micro to macro progression. We're going to cover defining clinical shock, cellular and microvascular cascades, systemic compensatory responses, classifications of shock, and finally, clinical hemodynamic profiling.
All right, part 1, defining clinical shock.
So the crucial takeaway here is that shock is absolutely not just low blood pressure. It's way more fundamental than that. It's a systemic state of low tissue perfusion that's completely inadequate for normal cellular respiration. Without enough oxygen and glucose getting delivered, our cells are forced to abandon aerobic metabolism and switch over to anaerobic metabolism. And if that perfusion isn't restored quickly, well, cell death ensues. It's a literal race against the clock at the cellular level.
Moving right along to section 2, cellular and microvascular cascades.
Let's actually trace this deadly cellular cascade. It's kind of like a terrible domino effect. First, as perfusion drops, cells get starved of oxygen and switch to anaerobic metabolism. But here's the catch. The byproduct isn't carbon dioxide, it's lactic acid. When enough tissue is underperfused, this acid just builds up, causing a severe systemic metabolic acidosis. Next, as intracellular glucose is completely used up, even anaerobic respiration stops cold. This leads right into step 4, the total failure of the sodium-potassium pumps in the cell membrane. Finally, the intracellular lysosomes just burst open, releasing these destructive autodigestive enzymes. The cell literally bursts, cell lysis ensues, and all those dangerous intracellular contents, especially potassium, get dumped straight into the bloodstream.
But the nightmare doesn't stop at just one cell. If we zoom out a bit to the microvascular level, we see a parallel disaster happening. The local tissue ischemia, hypoxia, and acidosis act like an alarm, triggering the immune and coagulation systems. This primes the leukocytes and activates complement, which then generates oxygen-free radicals. These radicals and cytokines go rogue and actively destroy the capillary endothelial cells. So that damaged endothelium loses its tight integrity and becomes totally leaky. Fluid just pours out of the vascular space right into the tissues, causing profound tissue edema. And here's the really vicious cycle. That swelling physically increases the distance oxygen has to travel, which directly exacerbates the exact cellular hypoxia that started this whole mess.
All right, section 3, systemic compensatory responses. Let's see how the body tries to fight back. First up is the cardiovascular system. As both preload and afterload drop, baroreceptors immediately sense the danger. They trigger a massive compensatory spike in sympathetic activity, basically flooding the circulation with catecholamines. This leads to 2 immediate desperate survival tactics: tachycardia to ramp up cardiac output, and profound systemic vasoconstriction to keep that blood pressure up. Now, I will note one major exception to this vasoconstriction rule, and that's sepsis, but we'll cover that unique outlier in just a minute. Meanwhile, the respiratory system kicks into high gear. Remember that accumulating lactic acid we just talked about? Well, the resulting metabolic acidosis, combined with that heightened sympathetic response, drives up the respiratory rate and minute ventilation. The lungs are rapidly trying to blow off carbon dioxide to chemically buffer the acid. This effectively produces a compensatory respiratory alkalosis. Simultaneously, the kidneys are sounding their own alarms. The decreased perfusion pressure at the kidney causes a sharp drop in glomerular filtration, so you get decreased urine output. This drop kicks the renin-angiotensin-aldosterone axis into action, which drives even further systemic vasoconstriction while aggressively commanding the kidneys to reabsorb sodium and water. It's basically a desperate attempt to keep the circulating volume from dropping any lower. Finally, the systemic endocrine response bolsters all of these efforts. A drop in preload triggers the release of vasopressin, antidiuretic hormone, forcing the renal collecting system to resort pure water and triggering even more vasoconstriction. Cortisol is also dumped from the adrenal cortex. Not only does it help hold on to sodium and water, but it crucially sensitizes the body's cells to those circulating catecholamines. It's basically turning up the volume on the cardiovascular system's earlier response. Let's shift to section 4, classifications of shock. We'll start with hemorrhagic and hypovolemic shock. This is hands down the most common form of shock. It's caused by a critically reduced circulating volume. Now, this can be directly hemorrhagic, literally bleeding out, or non-hemorrhagic from massive fluid losses like severe vomiting, diarrhea, dehydration, or even urinary losses in conditions like diabetes. And hey, don't forget third spacing. That's where fluid isn't lost from the body itself, but gets sequestered into the GI tract or interstitial spaces, like what we see in bowel obstructions or pancreatitis. Keep in mind, hypovolemia is, to some degree, a component of almost all other forms of shock. It absolutely must be excluded or treated, no matter what else is going on. Next up, we have cardiogenic and obstructive shock. Both of these result in a critically low cardiac output, but for entirely different reasons. Cardiogenic shock is a primary intrinsic failure of the heart muscle itself. Think a massive myocardial infarction, dangerous dysrhythmias, or severe valvular disease. Interestingly enough, this can actually present with venous hypertension and pulmonary edema right alongside your classic shock signs. Obstructive shock, on the other hand, is an extrinsic mechanical blockage that physically prevents cardiac filling. The pump itself is totally fine, but it just can't fill due to something like cardiac tamponade, a tension pneumothorax, or a massive pulmonary embolus. Then we have distributive shock. This includes things like septic shock, anaphylaxis, and neurogenic shock from spinal cord injuries. Now, this one acts as a really stark clinical outlier. Instead of that classic compensatory vasoconstriction we talked about earlier, distributive shock is characterized by massive vascular dilation, low systemic vascular resistance, and, as a direct result, an abnormally high cardiac output. In anaphylaxis, it's driven by a massive histamine release. In neurogenic shock, it's a sudden loss of sympathetic tone. And in sepsis, bacterial endotoxins activate overwhelming immune responses. That causes profound microvascular maldistribution, arteriovenous shunting, and a complete failure of the cells to even use oxygen, which is often complicated later by hypovolemia and myocardial depression. Our final category is endocrine shock. Now, this one can be a real clinical chameleon because it can present as a confusing mix of the other shock states. For example, severe hypothyroidism can completely mimic neurogenic shock because of low inotropy, bradycardia, and disordered vascular responsiveness. Conversely, thyrotoxicosis can throw a patient into high-output cardiac failure. Adrenal insufficiency, whether from Addison's disease or relative to severe sepsis, leads to hypovolemia and a dangerously poor response to both circulating and administered catecholamines.
All right, let's pull this all together in Section 5, Clinical Hemodynamic Profiling.
This table is absolutely crucial. It organizes the key cardiovascular and metabolic characteristics across the 4 main shock phenotypes. You'll notice a glaring common thread here, an incredibly high base deficit across all types. That represents the shared systemic lactic acidosis stemming from cellular hypoxia. But take a look at distributive shock down at the bottom. It clearly isolates itself with a high cardiac output, low systemic vascular resistance, and high mixed venous saturation. Why? Because the blood is literally shunting past the tissues, bypassing the very cells that are starving for oxygen. In stark contrast, hypovolemic, cardiogenic, and obstructive shocks all feature low cardiac output and a compensatory high systemic vascular resistance. To differentiate hypovolemic from the heart-related shocks, you just check the venous pressure. It's low when the tank is empty, but high when the heart is actively failing or obstructed. As we wrap up this explainer, I really want to leave you with a vital concept. Human pathology rarely follows a single, neat textbook pathway. All of these shock states are defined by systemic tissue hypoperfusion, but remember that different states can, and very often do, perfectly coexist within the exact same patient. You might have a patient in septic shock who then develops hypovolemia from capillary leak and later suffers cardiogenic shock from myocardial depression. Recognizing that these incredibly complex mechanisms overlap is the final essential step in mastering bedside management. So I'll leave you with this question to ponder. When you're faced with a patient exhibiting signs of multiple shock states simultaneously, how will you prioritize treating these overlapping physiological mechanisms to reverse that deadly cellular cascade? Thanks so much for joining this explainer, and keep mastering the physiology.